And this session, leading our discussion from carers, those who are caring for our patients, is chaired by our Executive MBA alumni and co-founders of our UCD Leadership and Healthcare Network. So first up, we have Sinead Ryan, who's a superintendent pharmacist and consults to industry and is a member of a number of boards and committees in the healthcare industry. We also have Dr. Knut, who's Principal GP and Clinical Director. Okay, so over to you, Sinead. Thank you.
Thank you, Geraldine. Throughout this pandemic, frontline workers have worked tirelessly at providing care for all our patients. This session is devoted to the patients' carers and hearing their voice of the impact of the pandemic on the care of patients with cancer and cystic fibrosis. I'm delighted to introduce to you Catherine O'Brien, an advanced nurse practitioner in cancer care in St. James's Hospital, where we'll discuss the care of cancer patients throughout this pandemic. Following that, we will hear from Emma O'Grady, also a pharmacist and a PhD student here in Smurfit School. She will share with us how Temple Street Children's Hospital have adapted their service delivery to children with cystic fibrosis in response to the challenges imposed by COVID-19 restrictions. Catherine, thank you for joining our discussion today. Catherine, I think you might be muted.
Yeah, no, I'm there. Thanks, Sinead. Yeah.
Thanks, Catherine. So much has changed in healthcare in the past 6 months. Take us back to the middle of March and the start of lockdown. How did your cancer patients' pathway change during this time?
Yes, so Sinead, my role actually as a cancer survivorship advanced nurse practitioner changed temporarily at the end of March. A number of our medical team had to self-isolate as COVID contacts, so I was redeployed to the daycare clinics to review patients who were attending for their cancer treatment. And as an advanced nurse practitioner, I have a huge amount of experience in this area, and together with my specialist clinical skills, including my prescriptive rights, this meant I was able to change very quickly into the role, which was great, and I continued there for about 3 months. Now, for our cancer patients, this was a very stressful time. These are a very high-risk group of patients, and suddenly their fear changed from dying from cancer to dying a horrible COVID death all alone, and they were just terrified. So very early on, we realized we needed to make changes in the processes to keep both our patients and our staff safe. So one of the first things we did, we set up a COVID screening pod at the entrance to the unit, and this included putting in a thermal image scanner. And all of our patients and our staff had a COVID assessment carried out every day. Unfortunately, we also had to restrict family and friends attending with the patients, which was hard for some because they were used to having somebody with them. But to be honest, the patients understood really why we had to do that. Another area then we looked at was the length of time of the patient's visit in the unit, because some of the treatments can be, you know, fairly quick, but unfortunately sometimes there's a few hours of a visit there as well. So we took a number of steps then involving the whole multidisciplinary team, from the admin staff, phlebotomists, pharmacy staff. It was a real collaborative approach, and everybody takes a part in this process. So we all had to look at what our current practices were and see if there was any changes, even small changes we could make to make the entire process more efficient. And a very good example of one of the very small changes we made was that the nurses used the electronic treatment planner to communicate with the pharmacy compounding unit where the drugs are actually compounded, rather than what we would have done before was everything by phone. It's obviously less time consuming. It was a very simple step, but it actually made a huge difference in the long run, which was great.
Catherine, were there any positive innovations that you've maintained throughout this period?
Yeah, probably the biggest change I'd say was the move to telemedicine. Throughout the whole time that I was redeployed to the day unit, I continued my cancer survivorship clinics. So nobody missed any appointments, even though my role had slightly changed. Those appointments just changed from face-to-face to phone or video call, and actually the majority have stayed this way to date. There's only a small number that come to face-to-face to my clinics. And cancer survivors are a perfect cohort of patients for the virtual clinics. I mean, they've finished their treatments and they're moving to life after cancer. So the focus of my clinic is ultimately to put the whole traumatic cancer event behind them and move on to a new healthy life. And often coming back to the hospital can be very stressful for them, and it brings back bad memories. But the telemedicine means that their consultation can be in the comfort of their own home, even in their workplace, because some of my patients are at work and they just take a break from meetings to do their consultation with me. And there's also financial benefits, of course, because they don't need to take time off work. There's no travel, there's no paying for parking, and these things can be huge bonuses for the patients. And the hospital obviously benefits as well, because there's very few missed appointments, because no matter where the patients are, they just need to answer their phone. And I know it's not for everybody, but I have to say a huge number of my patients have really embraced the new virtual clinic concept, and they're delighted to continue it with these for the future appointments.
Thank you, Catherine, for your fascinating insights and joining us today to inform us of the impact of COVID-19 on cancer patients. Emma, welcome, and thank you for bringing your experience as a pharmacist in Temple Street Children's Hospital to inform our conversation today. As a key member of the multidisciplinary cystic fibrosis team at Temple Street, did you identify any positive changes to patient care that arose from restrictions imposed by COVID-19?
Hi Sinead, can you hear me?
Yes.
Great. So yes, we have, and I actually think this is particularly interesting given the negative impact that restrictions have imposed as a whole. So cystic fibrosis is a chronic progressive disease, and our patients and families, they live strictly to very high burden regimens, regular scheduled clinic visits, and time consuming treatments, as well as inpatient stay. So from a patient perspective, anecdotal evidence tells us that restrictions imposed by COVID-19 and the transition to the virtual clinics that we are attempting to deliver have been a welcome break for our patients and families. And some have, I know from feedback as well from other centres, some patients have reported that their quality of life has improved, as well as having more time to actually complete their treatment regimens. From a team perspective, we continued to conduct routine clinics as best we could, and this was all done remotely through the peak of the pandemic. And we supported our patients from a distance, which actually awarded the team an opportunity to discover ways in which we may be able to maintain our standard of service by a virtual means.
I believe you're doing a PhD here in Smurfit in the area of value-based healthcare and teaming of cystic fibrosis. Has COVID-19 sparked any new directions or challenges in your research?
Absolutely, and I'm sure a lot of researchers are in the same boat and have faced some challenges and obstacles through the pandemic in terms of research. So life expectancy for people with CF has increased significantly, partially as a result of more effective treatments that are available, and crucially because studies show that patients who attend CF centres under specialist multidisciplinary care have better well-being and lung function compared to those who don't. So effective collaboration and communication really is central to this success of the MDT. And this comes back to a lot of what has been mentioned by previous panelists this morning. Collaboration, not just within the team, but also with the patient in order to achieve health outcomes that matter to them most. And restrictions imposed by the pandemic have really propelled us into this new and unfamiliar way of working together. And these changes have impacted on the team, but also on the patient. And as we await further national guidance in relation to living with the pandemic, we remain focused on individualised patient care and treatment options. So therefore, in collaboration with the healthcare research team in UCD, I'm preparing to conduct my research really in the area of team-patient cohesion, with a focus on interdisciplinary collaboration and innovation. And this will include maintaining and improving on these standards of care as we adapt to new dynamics that have been imposed on us during restriction measures. But it takes me back to what I said previously. in terms of a welcome break for the patient. You know, could it be that we can review our processes? Are we over-treating some patients that are maybe in a healthier cohort compared to others? And how might this affect cost in a value-based healthcare model? So there's definitely huge scope for a number of new directions in research during these unprecedented times.
And finally, Emma, what in your opinion has been the biggest challenge in maintaining multidisciplinary care to your patients during this pandemic?
I would think team proximity has been one of the biggest challenges. We've certainly experienced a bit of a negative impact in how we work effectively as a team as a result of not having this close proximity as we previously would have. So the richness of face-to-face contact versus the leaner remote communication within the team has been evident. And our ability to find each other in the unit, to share information and create solutions, which would have been quite easy to do previously. But you know, as Dr. Glynn alluded to earlier, we were never in a position to hit the ground running with virtual care and collaboration, and ICT infrastructure and training for staff, for healthcare staff, need time to catch up and need resources behind it. But ultimately, as we enter into this winter period this year, our focus remains on achieving shared goals that place our patients at the centre of care, whilst we adhere to the national guidelines and restriction measures.
Thank you, Emma. Your insights have reaffirmed the importance of creating and maintaining opportunities for multidisciplinary collaborations, and that's what our network is all about. I would now like to hand you over to my co-founder, Knut, to continue our panel discussion.
Thanks, Sinead, and thanks to Emma and Catherine for a really interesting insight on how to maintain non-COVID services during the pandemic. I'm delighted to co-chair this session as co-founder of the UCD Leadership in the Healthcare Network. And really, collateral damage will only come in time, and it's clear that there'll be delays in treatments. They're going to have a profound impact in our health service. And to continue on this theme, I'm delighted to introduce Professor Mark Lawler. Mark is Associate Pro-Vice-Chancellor and Professor of Digital Health in Queen's University in Belfast. And Mark is going to talk about ensuring that cancer doesn't become the forgotten C in COVID-19. Over to you, Mark.
Hi, my name is Mark Lawler. I'm Associate Pro-Vice-Chancellor and Professor for Digital Health at Queen's University Belfast. Really happy to be involved in this inaugural conference, and hopefully you'll be interested in hearing what I have to say. So I've deliberately given it the provocative title of Don't Let Cancer Become the Forgotten C in the Fight Against COVID-19. And this really is work that we've done over the last 6 months, which has been really pertinent in the midst of the COVID pandemic, but particularly the effect of COVID-19 on cancer and cancer services, and most importantly on cancer patients. So the original spark in relation to this was actually a conversation I was having with Edward Vidoliak, who's an oncologist colleague of mine from Croatia. And what he said was patients are starting to fear a COVID-19 diagnosis more than a cancer diagnosis. That really worried me. And well, anecdotally in the United Kingdom, we'd heard suggestions in relation to there being problems in relation to COVID-19 and cancer services. There wasn't really any data out there at the time. So we started a data-driven collaboration between ourselves in DataCan, which is the UK's National Health Data Research Hub for Cancer, and University College London. We looked at two different things. One was looking at real-time data from hospital trusts, and the other was looking at modelling excess deaths. So if we just look at the real-time data analysis first, what we looked at was what is called 2-week wait time. So that's essentially urgent referral or red flag referrals. So this is an early warning system for the suspicion of cancer. And then also we looked at chemotherapy attendances, which is really a proxy measure of the health of the cancer service, particularly it's the treatment pathway. And this just shows you some of the data. So just to orientate yourself here, and I'm just going to focus on these boxes here, both on the left and on the right. On this side, it's the diagnostic pathway, so 2-week wait. So what we're seeing is in different hospitals throughout the United Kingdom, as we go into COVID, we see a very significant drop in relation to either urgent diagnosis, or if we look over here in relation to treatment. And this doesn't matter whether you're looking in different parts of the UK or in Northern Ireland, where we looked at all the 5 different cancer trusts. The net result was that we were seeing, in relation to 2-week referrals, a 70% drop. So this is a 70% drop in relation to this early warning system, and 41% in relation to chemotherapy. Now, we're very used to hearing figures and numbers and percentages, but what does that actually mean? Well, what it means is that 7 out of 10 people with suspicion of cancer were not getting referred to their cancer specialist services. And similarly, 4 out of 10 cancer patients were not getting access to their chemotherapy. So very profound indirect effects of the COVID-19 pandemic. We were the first to draw this attention to the government, to academia, to the National Health Service and the public of this really disastrous effect of COVID-19. We shared it with the 4 chief medical officers, with the National Cancer Director, and also with SAGE, the emergency committee that feeds into government policy. So why did we need to look at real-time data at all? So what I'm showing you here is national data, which is actually showing you on the 9th of June what the data looked like in relation to red flag referrals or 2-week wait time, so urgent diagnosis. And what you can see here is really not very much. And the reason why you don't see very much is if you look at it, although this was looked at on the 9th of June, the data itself is actually only from March. So it's nearly 3 months out of date. And it's actually before the pandemic has actually happened. So you're not really seeing any change in relation, or any significant change in relation to 2-week wait data or urgent referrals. If you contrast that with our data, which we're looking at weekly over a long period of time, but this is the crucial period to look at, what you can see here is this nadir in relation to this drop. And then you're starting to see actually a re-emergence as the services start to respond based on our data in terms of restoring cancer services. What's particularly pertinent here is, again, same look, 9th of June, so looking at exactly the same time, where our data is from just 4 days earlier, the 5th of June. So therefore showing you why you really need real-time data to make healthcare decisions. So the disruptions, unfortunately, due to COVID-19 have occurred across the cancer pathway. So in terms of screening, you can see nearly stopped, very significant drop in relation to referrals. Also emergency presentations. This is important, 40% drop in A&E. We would have seen exactly the same in Ireland. And the reason why this is important is we actually see a significant proportion of patients who we diagnose with cancer come through accident and emergency. Obviously, if patients are not attending, or citizens are not attending accident and emergency, then they can't be looked at in terms of whether they have potential suspicion of cancer. Similarly, in relation to diagnosis, you can see particularly for something like MRI, over 50% of MRI scanning was not happening during COVID. And similarly, not only the chemotherapy data that we showed, but also similarly for radiotherapy and surgery. So significant effects in relation to those services, and also a 30% drop in relation to clinical trial activity, and also labs shut down, translational research not happening. We also then decided to look, well, what's going to be the effect of this in relation to potential excess mortality? And we're very fortunate here that we're able to look, this is just in English data, but a very important data set. It's called Calibre. It's a linked primary and secondary care linked data set of 3.8 million of the English population. We modeled different scenarios, and we used that real-time data that I just showed you to really look at what the effect was and to inform the model. And what we can see here, I'm just going to go down to the bottom line, between 7 and 18,000 potential excess mortality due to the effects of COVID on the cancer services and cancer patients. Also, interestingly enough, this data set is really rich in terms of having different comorbidities or additional health conditions associated with people who have cancer. And we're able to see in that 80% of those cancer patients who are at risk of excess mortality also had at least one comorbidity or underlying additional health condition. And these range from cardiovascular disease, hypertension, obesity, diabetes, COPD. The reason why this is important is that we can potentially intervene in some of these diseases, for example, in relation to hypertension or behavioral aspects in relation to obesity. And so therefore, we can potentially reduce the risk of excess mortality due to COVID-19. Just looking at some Northern Irish data here specifically, this was looking at a number of pathology samples, so that's an indicator of those that are diagnosed with malignant cancer. And what we're seeing here is comparing it with 3 years previously, 2006 to 2019. What you can see then again is in 2020, that precipitous drop, 31% in relation to the drop that we're seeing in cancer diagnoses. And then if we look in particular diseases, lung cancer and prostate in particular, going above 50%. I mentioned cancer clinical trials, which just shows you the Northern Ireland data, 80% of clinical trials suspended. So absolute profound effect on the entire cancer health system and the cancer pathway. And this is just some other evidence that we presented in relation to other data that we published just recently in Lancet Oncology and in Dutch, and also a paper that's coming as an opinion piece. Just don't have time to talk about this, but what's been the real effect here? I'd suggest we're going one step forwards, two steps backwards. So this is just showing you for lung, for breast, and for colorectal, the progress we've made over the last 10 to 15 years. You can see increasing 5-year disease-free survival here, you can see across the piece. But what I'm saying is that for lung cancer, for example, we're now seeing that we're actually going back 2 steps. So now what we're seeing is the actual effect of COVID-19 has meant that we're only at 2017 levels in relation to lung cancer 5-year survival. More profound in relation to breast cancer, we've sort of had an 8-year regression. And for colorectal or bowel cancer, it could have set us back nearly a decade. Now, these are modeling studies, but again, we really should take notice of them. The work that we did then, obviously at the time we did it, really we're probably one of the first in Europe to do this. Other researchers have followed our approach. We presented our data to the European Cancer Organization, which is Europe's largest multidisciplinary cancer organization, and on foot of that, they've really asked us to help them in relation to co-leading a special network on COVID-19 and cancer. This is going to be really exciting because it'll allow us to tease out what different countries did and what we should think of as best practice if we face into a second wave or future pandemics, or also future challenges to the resilience of health systems. And what was the impact? Impact very significant. As I said, we shared this data pre-submission with all 4 chief medical officers and also with the National Cancer Director and with SAGE. We feel it definitely contributed to that decision to start restoring cancer services. The APBI really said that this approach that we use, particularly the real-time data, really should be there at all times so that we can restore the standards of care in cancer. Research community, over 18,000 hits on ResearchGate, a lot of publicity, media questions to the Prime Minister the first day after he came out from his COVID-19 hospitalization, a program on cancer and COVID on Panorama, and then also the phase 3 letter from the CEO of the NHS, Simon Stevens, really highlighting that the first priority for recovery is cancer. What are the implications and actions? Well, an influential recent report from Carol Farrer and the Institute for Public Policy Research has quoted our data quite widely. And even just 2 days ago, the Health Secretary, Matt Hancock, was questioned by the Health and Social Care Select Committee based on our data. So just in conclusion, what I'd like to say is our research really has shown that excess deaths and significant perturbations of cancer care have really had profound implications on health services globally, and we really must address this urgently. I think we're highlighting how the power of data is so important, and really that requirement for weekly data in near real time. So rather than the mantra that was parlayed by the UK government of follow the science, we're suggesting you should really follow the data. We also feel that in our interactions with the different hospital trusts, and we're extending this real-time data network, we really think this has been a culture change in relation to data deployment in a fast, reliable, resilient way for better healthcare, but also sharing it responsibly. And the other thing I would say is getting back to pre-COVID-19 levels isn't enough. The new normal can't really be the same as the old normal. I would suggest that in order to address a lot of the bulk of what's happened in terms of misdiagnoses, in terms of delays in diagnosis in relation to delays in treatment, we really need to be operating at 130% of capacity going forward. One of the things we've tried to do then is look to see how can we use data to support the recovery. In colorectal cancer or bowel cancer, we see presentational delay, diagnostic delay, treatment delay, and this is leading to potentially significant excess deaths, but also loss of life. This is data that we just came out in the journal Gut, last week in relation to work that we've done that was led by Claire Turnbull from the Institute of Cancer Research, but we're collaborating on. And what we looked at is saying, why can't we prioritize the use of fecal immunochemical testing, so FIT testing, which highlights suspicion of cancer for patients, for individuals who may be at risk of colorectal cancer. And we feel that actually if we use this in symptomatic patients, we can avoid nearly 90% of the deaths that might be attributable to presentational or diagnostic delay, and also reduce the immediate requirement of colonoscopy, because the problem is we don't have enough colonoscopy units, particularly in the context of COVID, where not only do we have challenges in relation to the number of units, but also social distancing and sterilizing the suites between colonoscopies. So this can both help the health system by prioritizing the use of tests for those who most require them. So essentially looking at selecting out those patients who need this most and quickest and prioritizing them, but also it ensures that presentation or diagnostic delay are reduced. This is a short-term solution, not a long-term solution. We really need to have sufficient colonoscopy long-term, but it does at least help us in this to try and overcome the wave that we've seen associated with colorectal cancer. So I suppose my message that I said at the start, and hopefully I've convinced you, is that we really need to act, and we really need to act now. Otherwise, cancer will become the forgotten sea in the fight against COVID-19. Thank you very much for your time. I'm looking forward to the group discussion.
Thanks, Mark. It's a really interesting talk and reinforces the importance of real-time actionable data in cancer care. We'll have time for some questions from Mark after our next speaker, but for now, thank you very much. Of course, in Ireland, we face difficulties and continue to do so when it comes to COVID. But imagine caring for the most vulnerable people in extreme poverty with limited access to services, and then throw in a COVID-19 pandemic on top of that. Well, this is exactly what our next speaker does. Dr. Patricia Scanlon is a paediatric oncologist, a UCD Alumni Awardee, and she's founder of the aid organisation Their Lives Matter, based in Tanzania. Trish, over to you.
Good morning, everyone. My name is Dr. Patricia Scanlon. I'm a children's cancer specialist based in Tanzania, and I run a charity called Tumaini la Maisha, or Their Lives Matter. And thank you very much for the invite to speak today. And I would like to talk to you about how we managed our children's cancer service in Tanzania through the coronavirus. You may know a little about Tanzania already. You may have visited. It's beautiful, pristine beaches and Kilimanjaro and safari parks. You may think of healthcare in terms of the photo on the left here, where we have 3 children, all of whom have cancer, receiving care on a single bed in a very, very basic ward. The graph on the right shows the outcome for these children, and the pink column is the only one where children have a chance of survival, and this was very short-term follow-up, so in real terms the survival at this time was less than 10%. But thankfully this was 15 years ago, and we have really shifted the paradigm on this, and this is what I want to explain briefly before we talk about coronavirus. I need to show you what we were protecting. So we reached for the stars, and this is what we have currently. So flash forward 15 years, we now have a pediatric intensive care unit, a specialist pediatric oncology ward. We have a very active psychosocial service with a hostel, with school, with play, nutrition, and lots of fun activities. We also have a very, very secure diagnostic service, which has been really helped by Crumlin and other hospitals in Ireland, to a point where we now have the situation a child can come in sick in the morning, and by the afternoon we have a very detailed diagnosis and a secure plan for that child. What is different about what it is that we do? Well, it is free. It's free to all the children that enter the service. We share the cost, we, the charity, share the cost with the Tanzanian government. And to give you an example of how that works, so in 2009, we looked after 721 new children, although we do aim to get to 4,500, which is what is the predicted number of children annually getting cancer. In 2009, the cost was about €1 million, which we shared equally between the charity and the government. And does that sound a lot? Perhaps. But if you compare it to the European costs, there was a recent study looking at leukemia, one type of cancer, costs, and they tried to map the cheapest and most expensive care. Cheapest is in Finland, and it costs just over €100,000 per child. So for 10 kids in Finland treated for leukemia, we could treat 721. Also, our survival has improved from less than 20% to more than 65% in the short term, 1 year survival. And our long-term cure has improved from less than 10% to almost 50%. So we are making progress, though we still have some way to go. And then we were hit by coronavirus. So we began to think about this in March, mid-March, when things were locking down in Ireland. So what did we do? Well, we had to take all sorts of actions, and we were very strong in the planning in terms of different things that we needed to do. There was an issue around supplies, both routine and coronavirus related. There was issues around staffing and how we protect the staff and the service, and issues around infection control that we needed to change. So first of all, our supplies, well, we're based on the East African coast, and all of our supplies, routine and otherwise, come from India and China. And as you know, things were really changing in the world, and these supplies were locking down, and we were going to have no access to them. So we had to mop up all the supplies that were in the city. The hospital we worked in, which is a government hospital, was also feeling the strain. So we decided we would take over some of the supplies that they would normally give to the service. PPE became a very hot topic and something that we really worried about, because there was no PPE or very limited PPE in the city. And what did we do about that? We needed to protect the staff, we needed to protect the children. So the first thing we decided was we would put masks on everyone, children, parents, staff. This was not exactly what was being recommended at the time, but I think now is the guidelines that are being recommended. So I think we were ahead of the curve on this, and we're very happy that we did that. So what masks did we have? We had a limited supply of N95s, we had some surgical masks, and we had some cloth masks. And we were lucky that we had plenty of these because we engaged with the local community, all sitting at home bored. And they made us over 2,000 masks and cloth gowns and caps. And this was a huge, huge help to us. These were distributed to the staff, parents and children, and we decided that rather than having throwaway policies, we would try and reuse our PPE. This was easy, obviously, for masks or for cloth masks and gowns. They were soaked in bleach and then washed and ironed. For N95s, we decided we would also reuse those. So what we did was we gave everybody who had N95s, we gave them a small cloth bag. The dirty masks were put in the bag, and we sterilized using hospital sterilizers and UV sterilization and the bags, and then these bags were handed back to the individual. So although we reused the PPE, it was given straight back to the person, and there was no mixture in that sense. So that actually really, really helped and has kept everybody safe. We also gave hand sanitizer to everyone, small bottles and large bottles, so that everybody had it in their pockets, both staff and parents. And we insisted that they use it at all times. So the staff changes that were important. The first thing was we sent the vulnerable home. We did not lose any staff member. Everybody was kept on staff on full salary, but we just wanted to protect them. We also had a black swan, white swan approach. So we divided the staff into two teams, which was mixed with doctors, nurses, clinical care staff and admin staff. And then those two teams did not meet each other either in the hospital or at home. For those who were working, we tried to make them feel protected and valued. And so we provided food, both lunch and dinner, for those who were around. And we also took them off public transport and got them into private transport to make sure that there was no unnecessary risky contacts. Then we also had some new policies, which were all the routine new things, keeping 2 meters apart, and we didn't allow visitors onto the ward unless it was a palliative care issue, and we had health checks on the ward. So the costs, so our routine costs predicted for 2020 were over $600,000 for the year. And when we factored in the coronavirus costs, this went up to more than $1 million, which was obviously quite frightening because we did not have that money. But we're, over the last few months, have been very lucky that our supports of our donors and private individuals have reached out and helped us. So we have stayed afloat. How did we do in terms of the children? So the coronavirus impact, we would predict that every year we would see more children than the previous year. And we were on target at the beginning of 2020, if you compare the percentage from 2019 to 2020. As you can see there in April, May, June, and even July, this dropped significantly. It's now back up to similar numbers, and we're hoping that it will increase further. But we're at 90% of where we were in 2019, which is certainly not an improvement. So we have definitely missed some children because of this virus. So we're now living with this virus. The one thing I would say is the staff really did feel valued, and there was wonderful staff spirit on the ward at the time. So I was very happy about that. So briefly, just to let you know what was happening nationally. So it was very interesting in Tanzania. The government chose very limited preventive measures. There was a very brief lockdown of schools, universities, and international airports, which are now completely open. Mosques and churches and other things, they never closed. Businesses were allowed to choose what to do. People themselves individually wore masks, and hand sanitizer and washing facilities popped up at the side of the road all over the country. So officially, 509 cases were reported, and none since May of this year, and there were only 21 deaths. So why? Why so few cases and why so few deaths? Well, certainly the cases is definitely an access to testing issue. And there's one centralized lab, and there's no contact tracing. So they're definitely, for sure, underreporting the number of cases. But why so few deaths? And definitely, I would say again, there are no doubt some deaths that have not been recorded in relation to the virus, but and we would have, you could say perhaps because of the age of the population, but we had modeled the country, including the age profile of the country, and we would still have predicted about 200,000 deaths. So why did this not happen? Even given that there was an underreporting, you couldn't hide this number of deaths for sure. So we believe that what happened was there's just the risk factor profile is not in Tanzania, or it's very limited. 75% of the population are poor. That means they eat one bowl of rice and beans a day. They're manual labor working outside. And so they don't have vascular risk factors. And 70% of the population live rurally. So Tanzania is a vast country. So people are living in isolated places, and it's not circulating the way it would in Europe or North America. So that's the situation we have in Tanzania. And yeah, I welcome any thoughts or questions.
Trish, thanks so much for the amazing insight as to what's happening on the ground in Tanzania and the fabulous work that Their Lives Matter is doing. I'm joined by Trish and Mark now live for a very brief, unfortunately, Q&A. We're running very tight for time, and our coffee break has been eaten up. So Mark, I might just come to you first, if that's okay. And thanks again for a really interesting and frankly quite terrifying talk in terms of the number of cancer diagnoses potentially being missed. Based on your experience with the real-time data in cancer care, how important is getting this real-time data system up and running, and how quickly can that be done, changing from the kind of 6-month lag that we have at the moment to real-time data?
Thanks very much indeed, Knut. I think it's absolutely critical. I liken waiting on data that's 6 months old and trying to use it to make decisions of trying to fight cancer with one hand behind my back. It's really that serious that we really need to change our mantra, not accept what we've accepted in the past. And I think the use of data is incredibly important. I think you've seen it from a number of speakers this morning and in the chat and in the discussion. And yes, we should be looking at how we do that in the context of track and trace. We should be using the technology that we have. And the other thing I would highlight, is that we're now working a lot with Louise Burke and colleagues in the Faculty of Pathology and with Mary in the Royal College of Physicians of Ireland, because this is an all-island issue. It's not simply an issue in relation to the UK in isolation. So certainly very keen on looking at ways in which we can work together. But in order to do that, you need an electronic health record nationally that actually works in Ireland. So one of the things that should come out of this is really change the mantra and actually have an electronic health record. Why do we not have it? It's 2020. Why isn't there an electronic health record in the Republic of Ireland?
Absolutely right, and that speaks to a number of questions actually that have come in already that you've managed to cover off in one fell swoop. So fabulous work on that. I suppose just one quick follow-up. How long do you think it is before we're going to, or it'll be before we fully know the impact on 5-year survival rates and the impact on cancer care? Because obviously we're very early in this pandemic. It could well be a number of years, right?
No, absolutely. That's why it's critically important to collect data, and also it's critically important to collect data from across Europe, and that's one of the things we're doing as part of the European initiative that I mentioned, and because we really need to work together on this and share experiences, share best practice. But yes, we need to be following that data. And also the other thing is, yes, some of the data presented is very worrying, but there are ways in which we can intervene, but we need to intervene now. That's why I'm saying that it's just going back to what we were doing pre-COVID and saying, oh, we're back to 100%. I don't think that's good enough. We need to be working at least at 130% to actually deal with that bulge, those misdiagnoses that you mentioned. And so going back to the old normal is just not acceptable for our citizens and for our patients.
Sure. That's brilliant. Listen, thanks again, Mark, for an amazing talk. I'm going to move on to Trish now. Trish, fabulous and really inspiring work that you do. I suppose, can you tell us about what the situation is on the ground at the moment in Tanzania? It seems like a very different experience of a pandemic to what we have here. And is that because of differing testing rates, as you mentioned, or is it that actually it's just the whole societal effects, or the demographic society they live in Tanzania is very different, or is it a combination?
Well, so I think there's a sense that this virus is probably circulating in the community. I wish they had access to enough testing that they could show that while people are getting the virus, they're actually not getting very sick. Because I run the network of children's cancer services across the country, I speak to 6 hospitals every week around the country. And every time the first question is, how are things in terms of COVID? What is the ICU like? And none of the hospitals in the entire country are overwhelmed. There's a trickle of patients coming in with respiratory type illnesses. They're not testing, or if they're testing, we're not getting the answers. So we don't know. You can assume they are, but I think part of it is what I explained. I mean, there is a sense now from some of the scientists who are looking at this that there may be something in the immune system of perhaps people exposed to multiple infections. I mean, I'm not saying this with any data behind it, but it just seems very odd that with absolutely no shutdown whatsoever, that there isn't, there are people who have diabetes, there are people who are overweight in Tanzania. It's far less, but they're still there. They're still not coming in, and there's very few people dying. So I think it's a question that would be a great one to be able to get to answer. Someone suggested that falciparum malaria, the map of that across Africa, possibly might overlap with the map of who's not getting so badly affected by coronavirus. But again, I'm not a scientist, I'm a clinician, and all I'm saying is I'm very happy that we haven't had a single staff member sick. The policies we've put in place certainly seems to have worked, or as I say, maybe they're not as much at risk. And the children that we've looked after, those that have been affected back when we were able to test, we didn't have any very, very seriously ill patients or parents.
Great. We just got time for one final question. Well, we don't really have time for it, but it's important, so I think we'll ask it. And it really encapsulates, I think, a lot of what we feel about the work you do. It's come in from John, and it says, Trish, you and your colleagues are so inspiring as always. While acknowledging all that the Irish people have done and continue to do in combating this pandemic, what Trish, her team, and the Tanzanian people have and continue to do is truly exceptional, in spite of certain Tanzanian government's response. what else can be done, I suppose, from our side of things to get you back to 50% and better in terms of childhood cancer survivals?
Well, I mean, I just think, first, I thought it was fascinating, Mark's presentation, and I really was shocked by some of the figures that he presented, but it was interesting how it mirrored in what was happening in Tanzania in terms of how we've fallen back even from the little progress that we've made, but it seems like everywhere is falling back. To be honest, I would say that, you know, in Ireland, the support we get is like superb. I'm always so proud to be Irish. I'm always so grateful that, you know, like the NGO world is so supported into civil society in general, that, you know, this isn't the same in other countries. I get that constantly from other friends of mine from other parts of the world. They can never believe how much Ireland supports. The medical network is incredible and has really lifted the service from the very beginning to where it is today. So all I would say is thank you, and I just hope people will continue to help. That's all.
I'm sure they will. Listen, thank you so much to both of our panelists there, Professor Mark Lawler and Dr. Patricia Scanlon. Really interesting session, and really just, I suppose, it looks at the bigger picture about of the non-COVID issues affecting patients, which is just going to become more and more important in times to come.